Thank you very much for the invitation. So I'll try to speak slowly for the translator, and if I'm boring you, you can throw a banana to me and I will. Okay, so the one thing which is very important for me is when you're facing Erdheim-Chester disease, that the natural history is totally unknown. You have a couple of patients who have just a little bone pain or even no bone pain, a little CRP value, and that's all. And other patients who have much more severe involvement of the disease, like heart, CNS, and who unfortunately were the patients who would die in a couple of months or years before we had access to effective treatment. And the other thing is that seeing a lot of patients, and now we've been seeing in France more than 270 patients, is when you see a patient at the time zero, usually there is a kind of a phenotype where certain signs are present, and that the patient is going to keep these signs and not going to add, like when you see them a year after CNS when he didn't have CNS, or pericardial effusion if he had a normal heart status when you saw him at the baseline, at the first time you see him. That's a general fact. Of course, there are persons who do have other signs, but it's just to tell you that when we start seeing you at a certain, in the beginning of the disease, usually you do not add several other organs to your clinical presentation. So again, this is a disease with a multi-system involvement, and originally the disease was known for bone localization and rheumatic involvement, but I'm used to saying that it's a true disease for internists, because most of the patients have other, you can see other extra-osseous involvement. And I've listed here, it's a series from 3 years ago. Now we have more than 100 extra patients, but the percentages are about the same. And here are listed some of the signs that were not known back 15 years ago, like the coated aorta, which I will show some example, and some of the involvement around the heart or around the coronary artery. So first of all, the heart and the large vessels were described almost 90 years ago in the two first description, which was autopsic description of the heart and of the big vessels. So it can affect almost every organs from the heart and the big vessels, and it was there was a term that was coined by some French colleague, which was called coated aorta, and it was actually how I discovered the disease more than 15 years ago. And at that time, before effective treatment, before interferon alpha, and before, of course, targeted therapy, 1/3 of the patients died from cardiovascular cause. And this is a little bit more recent. This is from published last year, and when we looked at the series of patients in Paris, it was 165 patients, and we looked what was the predictor of poor survival using what we call the Cox survival analysis. And in multivariate analysis, when you have CNS involvement, it's bad prognosis. Cardiac involvement is not statistically associated with a poor prognosis. I say not anymore compared to 15 years ago. Lung involvement and also retroperitoneal involvement. So the heart and the large vessels, so this is what we call coated aorta. It's an infiltration sheathing the whole of the aorta from the origin to the iliac bifurcation. You can see it here at the thoracic level. It's about 1/4 of the published cases, and in our series it's almost half of the patient. And compared to other other causes of infiltration of peri-aortitis, there is no narrowing of the lumen, and usually there is no stenosis, so no vascular consequences of this peri-aortic infiltration. Something very striking we found a little bit 10 years ago, just analyzing larger and larger series of patients, and this has become one of the iconic feature of this disease, is what we call the pseudo-tumoral infiltration of the right atrium. And so it's like histiocytes who get here, and this is the right coronary artery, and this is another incidence. And so basically, if you add now out of 270 patients, it's still about 40% of the patients who have this kind of involvement, and it is very linked to the BRAF mutation that Philippe Jancu talked to you a little bit earlier. This is a view, it's an autopsy view of a heart of a patient who died, I think, 20 years ago in the city of Lyon. And so this is to show you that the heart was really infiltrated in all the layers of the heart, the epicardium, the pericardium, which is sickened here, and the valves. And so this is one of the reasons why it's important when you have this kind of involvement. Most of the patients who have this kind of involvement have a BRAF mutation, and hopefully this is good because you can have this infiltration regress or at least get less important. This is, you can imagine that when you have infiltration in the heart, so this is a CT scan of the heart, and this is the right coronary artery here, and this is a left coronary artery. And we don't know why there is a tropism, which is more important usually in the right of the body, even in the right of the pleura also. Anyway, it's one of the reasons why there are more myocardial infarction or more coronary issues among ECD patients than other patients. But sometimes it's difficult to know if it's due to the disease or if it's due to the age or to other cardiovascular risks, because if you are 50, 60 or 70, if you have smoked before or have high cholesterol, or if you have had steroids before, it can also be one of the reasons why you have coronary issues. So this should be looked and assessed in a very careful way when you have Erdheim-Chester disease. And you can have also an infiltration around the branches of divisions of the aorta. There are a couple of involvement of the arteries, the digestive arteries. Sometimes you can have the equivalent, it's very rare, but the equivalent of coronary angina with what we call mesenteric angina, which is pain, digestive pain, but it's very rare. You have also a couple of history of stroke due to the infiltration of the arteries that get to the brain, but it's also quite rare. The only thing where you should be cautious is when you have a sheathing of the renal artery, and about 20% of the patients have what we call renovascular hypertension. And when this is the case, it's very easy to put a stent in the renal artery, which you see here, and so then you can cure this aspect of the disease and cure the high blood pressure. One of the second involvement of the disease is cardiovascular involvement of the disease is pericardial involvement, and there are many stories where you have effusion around the heart, and when it gets too important, the heart cannot function normally, and it can get to a tamponade and eventually to death, which is a situation which has become almost exceptional, because most of the doctors now know that pericardial effusion and pre-tamponade or tamponade is one of the causes, Erdheim-Chester disease, and so the treatment is very simple. You put a needle or you start a targeted therapy, and this goes away. So the heart, sorry because some part is in French, but never mind. So the heart is very important issue, and this is a study we did in Pitié-Salpêtrière with, you see, more than 260 patients over the last 15 years. And this is a heart examination which were conducted in 205 patients. Most of them were MRIs, and you can see that among these examinations, half of the patients had an abnormal, had one kind of abnormality. And you can see that in this series, more than half of the patients were BRAF mutated, and it was mainly ECD patients, and also a couple of overlaps formed between Erdheim-Chester and Langerhans cell histiocytosis. And this is an example. The resolution is not very good, but this is what I showed you, the pseudo-tumoral infiltration of the right atrium, and it has some characteristic with hyposignal T2. And now again, when you have this involvement, you almost know for sure that this is due to Erdheim-Chester disease, and there is no indication for doing a biopsy of this. This can be quite a problem. Other striking, this is an infiltration in the right atrioventriculum groove, and it's an important location, because you can have heart blocks and heart rhythm issues. So when you have this kind of masses, you should see a cardiologist and have some electrophysiologic test of the heart, and also check what Lorenzo told you before, independently of the fact that you are or not under BRAF inhibitor for the QT interval. And when this gets massive, this is very rare, but you can see that this is all, what is dark is infiltration by the Erdheim-Chester disease, and it gets almost everywhere. This is the aorta, and you can see that the heart here is almost completely sheathed in this mass here. And you have also the infiltration around the aorta here, and you can see that the lumen of the heart is narrowed to almost nothing. This patient had no real signs of dyspnea or chest pain, so sometimes it's massive, but there is no parallelism with the heart symptoms of the patient. And again, another localization I told you, you can see here, this is the pericardial involvement, and you can imagine that the lumen of the heart cavities are thickened, and it's more complicated for the heart to function. But hopefully, with this is an example, and I'm sorry, this is in French, but never mind. So it's a woman with BRAF mutation, and you can see that after 1 year of vemurafenib, the various localization of her heart disease disappeared almost completely. A second aspect I want to focus on is the lung involvement, which in our experience in PTS-Salpêtrière is mainly most of the patients who have lung involvement defined by CT aspects with interlobular septal thickening. You can see here on this CT scan, and most of this lung involvement is not very much clinical. It means that a very little proportion of the patients, although they have this kind of involvement, do not need to have oxygen, do not have abnormality when you listen to the lung murmur, but nevertheless, it is still, when you look at the statistical test I showed you before, when you have a lung involvement, it's usually more severe, even though you do not have clinical evident traduction of the fact that you have lung involvement. And you can also have some little holes here, which you call cysts, and the cysts are quite rare in Erdheim-Chester disease, like it's little holes like that. And this is one of the characteristic of another disease, which is a very close cousin of Erdheim-Chester disease, which is Langerhans cell histiocytosis, which is more frequent, and the cysts are much more frequent in LCH than in ECD. Again, that is what I told you. When you have lung involvement, your prognosis is less good than when you don't have it. And when you have retroperitoneal involvement, your prognosis is worse than when you do not have it. The long bones, so this is one of the signs which is quite important in this disease. Also, one of the clinical signature of this disease is if you take almost all patients with Erdheim-Chester disease have long bone involvement, and when you look at this X-ray, you can see that the medullary cavity here is totally blurred, and you have a little osteosclerosis, which affects the extremities of the long bones. So this is a femora, and here you have the tibia. And even though you have this aspect, you do not have always bone pain. Bone pain is present in almost half of the patients. There is no particular timing of the bone pain. Sometimes it's very important, and patients need to have painkillers, sometimes opioid drugs, and sometimes although they have this kind of aspects, they do not mention bone pain. Even if you ask the patient, they say, no, I don't have bone pain, but they have very pathological aspects, such as this one, again, with, this is called endosteosis, and you can see it better, sorry, on this slide. You can have the feeling that there is a deformation and there is some accumulation of a thickening of the bone, both in the inside and the outside layers of the bone. If you have a doubt, you can do an MRI, and you can see that the normal signal of the bone is replaced by an hypo signal here, which affects almost all the femoral bone. Just there is a small region here which is spared by this infiltration. So it's different from another disease I mentioned, Langerhans cell histiocytosis. You have osteolysis, and this is a disease where you have osteosclerosis. You have condensation, and it's usually, which is not the case when you have LCH, and sometimes ECD, can be associated. In about 15% of cases, you have LCH plus ECD. Unfortunately, I do not have pictures of teeth and gums involvement. Basically, this is quite frequent. It's maybe 15-20% of the patients, and this is something that is very well known in Langerhans cell histiocytosis, where patients have parodontopathy and start losing some of the teeth, and it's about the same for ECD patients, and they should try to see stomatologists who are deeply aware of treating these patients and who know how to cure the teeth and gums of these patients. And this is one of the problems in many countries, and in France we have the chance in PT-Salpêtrière to have a colleague who is particularly aware of this. And something just close to the CNS I won't be talking on is one of the ENT localization is nearly 2/3 of the patients have an osteosclerosis of the sinuses of the face, and sometimes have major thickening of the skull vault, but sinusitis, chronic sinusitis is also an issue of the patients with Erdheim-Chester disease, although it's not always, there is not always a clinical relevant signs of sinusitis, but I think due to these radiologic findings, it's also important for patients to be addressed to ENT doctors to have their sinuses checked at least once at the beginning of the disease. Some of other more rare organ involvement, which I do not have images, the gastrointestinal and the liver, it's pretty rare in adult patients. It's mostly among younger patients with Langerhans cell histiocytosis, but we have a couple of patients who have massive diarrhea due to exudative enteropathy. It's patients who have basically diarrhea, and it's specific to a gut infiltration by histiocytic cells, and it usually responds very well to treatment and to targeted therapy. And there is an also very severe involvement, which is usually treated by by liver transplantation. This is affecting the biliary tract. It's called sclerosing cholangitis, and this is quite rare. I think we have less than 10 patients in Paris with this kind of condition. Sometimes it's very mild, but one of the problems is when it gets ongoing, you can develop cirrhosis with no treatment apart from liver transplantation. And if you are too old with this condition, then it's a problem. So I believe this is one of the conditions where we should be particularly aware and treat frontline with a targeted therapy when you have this kind of involvement. The eye, so this is actually one of the first patients treated in Paris with interferon alpha. It was in the late 90s, I think 1997 or 98, before I arrived in the department. And you can see he has a mild exophthalmos. It was not clinically relevant, and it got better with interferon alpha. He's tan here and not here, but well, the picture is not of evident quality, but sometimes it can be quite a problem. Like this patient who was diagnosed in 1995 or 1996, and he was treated at that time with autologous transplants, autologous stem cell transplant with high-dose chemotherapy and transplantation of his own cells. And you can see that he got better. Unfortunately, he relapsed, and it was before vemurafenib was licensed, and he died of other complications than his exophthalmos. So it can be sometimes very, very important, and you can see here, that's again a patient who died 30 years ago. I didn't know, but you can see here that this is one of the reasons of the exophthalmos is you have a sheathing here behind the orbits, and it's usually bilateral and not symmetrical, and hopefully this kind of patients now you have effective treatment and you don't see this kind of situation anymore without having effective treatment. Since more than 10 years, and most of the patients here know that, one of the key examination to assess the overall efficacy of the disease is a PET-CT, and it's one of the examination which has a good sensitivity and a good specificity compared to other imaging modalities, and it's a key examination to follow most of the patient, particularly those entering into clinical trials or who have targeted therapies, because you look at the uptake under treatment, and usually it gets better. And there is, so before you used to do, for instance, for the long bones, you used to do bone CT scan, and now an advantage of the TEP FDG is that you can cover the whole body with this examination and have quite a precise, quite a clear idea of the different involvement. One of the, I think I'll finish on that to say that we are opening a trial in Paris, which is opening either today or Monday. It has been quite a long time for trying to build it. And so as Philip Janku was mentioning, the idea is to enroll patients for BRAF wild type, and it encompasses ECD patient, ECD plus LCH, Rosai-Dorfman patient without the mutation. It's a randomized, placebo-controlled, and it's a double-blind study. You don't know what you're taking, and the doctors don't know what you're taking just for the 3 first months of the disease. So obviously, it is not a trial designed for a patient who has a tamponade or who has a major exophthalmos where you have to be sure you act fast and quick. But it's an interesting trial to, for many reasons. One of the reasons is to try to have access to the drugs in Europe, because vemurafenib, there is an FDA approval in the States, but in France, for instance, and in many European countries, you don't have approval. In France, we have the chance to have a social security that does not bother us too much, but maybe we could be confronted in the next months or so to cases where they are going to ask the patient to refund the price of the treatment, which are maybe 4,000 or more euros per month. So we need to get the approval in France and hopefully in Europe, because this is also addressed to European patients who could come to Paris, get the drug. The only problem is you have to get every month to Paris, but there are some worst situation, I guess. Anyway, so you start the trial, and after 1 month and 2 months, you are reassessed. If you are in the placebo, and if you worsen, then you unblind you unblind the study, and you can get the cobimetinib even at 1 month and at 2 months. And everybody after 3 months gets to get the cobimetinib, and so you get it for free for 9 months. And so this will be a real trial to show not only the efficacy, but that it's proven versus placebo. And so I guess that's the end of my presentation, because the other organs involvement will be developed later on today. Thank you very much.